Hello, I'm Dr. Emma Richards, and I'm presenting today with Chloe Tulip. We're both going to be talking about brace-funded vascular dementia, and we are both were funded to do PhDs. I completed mine in 2020, and Chloe's coming towards the end of hers now. So my dementia interest journey started many years ago, around about when I was about 17. My nan was diagnosed with dementia. Don't know really what type it was, but I went along with her to a memory assessment, and it stuck in my mind that she couldn't draw the clock in the tasks when they were asking her to do it. This combined with some comments on a sports science A-level that I was doing, which was psychology related, and then a job opportunity coming up in the hospital for people with dementia, all aligned together, and that became the start of my dementia research journey. Along the way, it's been a long journey doing my degree and my master's degree, and having 4 children in the mix as well. This has taken me some time. But anyway, a few years ago, I seen an advert for a PhD, which was looking at vascular dementia. And I hadn't crossed my mind until I'd seen this advert that there's something that I might like to do. But anyway, I was accepted to do it. And the PhD was looking at characterising vascular cognitive impairment. So the purpose of this was to identify some of the early signs and symptoms of the disease. And this was related to the way that the brain processes information, particularly visual attention. We wanted to contribute to a profile of what vascular cognitive impairment looked like. And we wanted to see if there were differences between people with vascular cognitive impairment and people of the same age on different tasks, so things like reaction time and how variable people's reaction times was, and the errors people made, and whether there was an ability to improve on such tasks. We wanted to look at it because the results then would contribute towards the overall building of a profile of people with vascular cognitive impairment and help identify the disease earlier. The results then will improve the knowledge and the importance of vision and attention and the effects of dementia for both the general public and for clinicians. And it'll also help it to differentiate it between other types of dementia. So as part of my PhD, I run lots and lots of different tasks on the computer, in paper and on iPads. But I'm going to talk today just about one of the tasks. And we had lots and lots of volunteers helping, and we looked at 3 groups of people. So we had some young adults, some cognitively healthy older adults, and then a load of people who were diagnosed with vascular dementia or vascular cognitive impairment. So in this particular task, participants were shown a computer screen with these 2 presentations. And the first one on the left, you can see that it's quite a simple screen, and it's a bit more complex on the right-hand side. And the participants' task were to identify whether the arrow was pointing left or right. So on the screen on the left, you can see it's quite easy to see, and the arrow's pointing right. On the other task, there's lots of distractor arrows, and some of these are pointing up and down, and they have to ignore these arrows and still find the one that's pointing left or right. And they have a box, and they press a corresponding button to say whether it's pointing left or right. And they do this 64 times. And this is to give us an accurate picture of somebody's visual attention and their responses. And it's better than some of the tasks that they're doing currently in memory clinic. So what we discovered, firstly, we looked at what the differences were between younger people, so aged 18 to 30, and older people, so anybody over 50 who didn't have dementia. So firstly, the young adults, their information processing speed, so their reaction time, how quickly they'd done those tasks was very, very fast. They couldn't improve because they were already doing so well. And there was very little variability in the tasks. So we recorded 64 time responses for each one of these. And all those times that they'd done were very, very quick. And there was very little variability in that. When we looked at the older adults' data, they were much slower in their processing tasks, and that was with and without the distractors. And this is perhaps to be expected because as we age, we do get slower. But they were able to improve their reaction time over the trials. So unlike some of the younger adults, particularly when there wasn't any distractors, but they were more variable. So some of their responses were fairly quick, some were a bit slower. So there's a bit more variability in the responses. What was interesting, there was no difference in the errors between younger people and older people. So age-related slowing might have an effect on information processing speed, but not on their errors. When we compared healthy older adults who didn't have dementia with people who had vascular dementia, so we matched them for age, we've seen that people with vascular cognitive impairment had slower processing speeds. Their reaction times were slowed. They were much more variable in their reaction times, and they were unable to improve this variability within the reaction times, even with practice. So this indicates the presence of disease, but it also highlights the importance of testing for this within memory clinics. So when distracting information is present, so when you see on the screen with the lots of arrows, there is more detrimental effect on reaction time. So particularly when the distracting information was there. So again, this needs to be included in tests of in memory clinic tests. So people with vascular cognitive impairment were disproportionately slower when we added these distractors in compared to the cognitively healthy older adults of the same age. There was an increased errors by the people with vascular dementia, particularly both with distractors present and when there were no distractors at all. So this reveals that even when there's only a small amount of brain resources needed, people with vascular dementia still produced more errors. So this indicates a breakdown in the processing networks within the brain, and errors didn't improve even with practice. So thinking about this in real life, these are tests that have been done on a computer in a lab. How can we think about this in real life terms? So the reaction time is your ability to be able to see something and detect it, process that information in your brain, and then respond. And we combine this with this visual search task. So the impact was great when we put distracting information into the computer screen. So for real life, this can be a huge problem because there's always distracting information in people's environments. So there's clutter, there's always other things around, things don't happen in isolation. So I tried to think of some examples, and you can see here I've put a picture of some spice jars. So perhaps being able to find an item amongst some clutter, I've asked them to find the ground cloves, but they would take them a bit longer than somebody who's of the same age without vascular dementia. But even more important, and even with catastrophic effects, the ability perhaps to drive safely, being able to brake in an emergency situation, the reaction times are much slower. And also, when you're driving, the environments are busy, the roads are busy, there's lots of other things in the environment. Being able to cross a road, if you step out into a road and then need to withdraw because there's a car coming, too fast, your reaction time is slowed, and that can cause people problems. There's an increased risk of falls. So if somebody stumbles, their reaction time to be able to grab onto a handrail or to grab somebody near them is reduced. And perhaps even to detect danger, if somebody sees a tea towel smouldering and they need to respond, there may be a delay in that response. What we've got to remember is that people with vascular dementia, their reaction times are variable. So it can be that in our tests took about 3 or 4 minutes, and within that time we've seen great variability. So they were able to react very, very quickly sometimes. But then on the other hand, they reacted very, very slowly. So when we drew the graph, they were much variable on this graph. And finally, there's the implications then for clinical practice, because a lot of this isn't added into the clinical assessment when making diagnosis. So we also know that there are many other factors can influence reaction times. So medications that some people take can cause them to be thinking much slowly and process information, and having certain conditions such as depression, or even just visual and auditory impairments. And of course, there's the sleep quality. It can also affect somebody's ability to react quickly. And this is where I will hand over to Chloe, who's going to talk about sleep and dementia. But before I just do this, I want to say that completing my PhD would not have been possible without the funding from Brace and the support of all my participants. So thank you.
Okay, so I'm absolutely delighted to be here to talk about my PhD, which is Brace funded, so that's excellent. And the focus of this talk is on sleep and dementia. So obviously we spend about a third of our lives sleeping, and what it does for us is actually quite remarkable. So it's not just a case of you fall asleep, you do nothing for 8 hours and wake up again. It's actually a really active process, and in certain stages of sleep, actually, brain activity is sort of comparable to wake, so there's lots of things going on. But mainly, the main role of sleep, sort of in a broad nutshell, is to maintain a healthy mind and healthy body. With that being said, great. On the flip side, poor sleep actually has a host of negative consequences on pretty much every system in the body. So we know, unfortunately, that people living with dementia are actually more likely to suffer with sleep complaints. So some estimates sit at about 1 in 3. Obviously, they're quite variable, but it seems to sort of sit around that number. And this poor sleep is actually associated with distress, more severe cognitive and neuropsychiatric symptoms, and it's actually been associated with accelerated cognitive decline. So that can lead to a poorer disease prognosis. Okay, so for example, the presence of insomnia in midlife is actually associated with a twofold risk of vascular dementia. And similarly, I've sort of put together some other aspects of poor sleep and their risk, and you can see that they're, elevated. So what that suggests then is that poor sleep not only increases our risk of developing dementia, but perhaps is a symptom of dementia due to how common it is. But it can also make prognosis worse. So you can see that in some scenarios, this might actually lead to a cycle of deterioration. With that being said, the majority of sleep research actually focuses on Alzheimer's disease, and vascular dementia is the second most common form, but comparatively much less is known regarding, sleep in the role of the disease. So that's sort of where my work comes in a little bit. Okay, so my thesis has sort of a three-pronged approach to develop our knowledge about sleep in vascular dementia. So the first area is, does poor sleep make cognition worse? So it's understanding the impact of poor sleep on our thinking processes. And then the second aspect is looking at memory formation and sleep, which I'll talk about all of these things a little bit later. And then the third aspect is, what can we do to improve sleep? So for the first part, sleep and cognition, I'm actually using a large database which has over 1,000 kind volunteers with vascular dementia. And it's kind of similar to Emma's work. I'm going to be looking at several different cognitive tasks and looking for associations or relationships with poor sleep and also sleep disorders as well. Okay then, so for the second part of my thesis on the role of memory formation in sleep, so not only could this help us kind of develop our knowledge about memory systems, but the tasks that I've developed might actually help serve to aid diagnosis of vascular dementia. So research shows that sleep is incredibly important for forming new memories. And it's really important for moving memories from short-term to long-term storage sites in the brain. So a nap as short as 6 minutes can actually boost memory. So if you ever want to learn something new, have a little sleep and you'll do much better. But research also shows that emotional content is actually probably given a special boost or a preferential boost. So there's been tons of studies on this where people have been asked to remember a bunch of different pictures. So, I don't know, like ice cream or like a gun pointed at your face. so a positive, negative, neutral. And when you sleep, you're more likely to have A, better performance, but B, actually have a better memory for the positive and negative stuff and not the neutral. Okay, so I've actually used a task similar to this. So there've been lots of studies on pictures, and there've only been a real handful on studies using this kind of paradigm using words. So I've developed a new story task where there's about 12 different stories of all different emotional content. And I'm asking people to sort of look at, well, try to remember them before they go to sleep, and then also remember them in the day to compare wake and sleep. But anyway, why am I talking about this? What has this got to do with dementia? So I'm going to give this task to 50 adults living with vascular dementia. And an important research question that I have is, does memory get worse over a period of sleep, or is it preserved at a normal rate? So again, this will help us to understand some of the basic mechanisms of the role of sleep in memory for people living with dementia. And also, as there's 12 different stories and all of them have 160 words and they've been piloted and validated, that actually means that we could have the potential to capture very subtle changes in memory over time, which might perhaps aid diagnoses. Okay, so the last part of my thesis is perhaps to me the most exciting. So whilst it's really helpful to know that, you know, poor sleep has all these negative consequences, it's only so much as important as we can actually do something about it. So luckily, there are ways to improve sleep that have been tried and tested, you know, thanks to research. But many of them actually require some sort of input from a facilitator or a care provider, or can be quite costly. And so what that means is it's not actually accessible to everybody. And if we've learned anything from COVID, it is that care systems are struggling, really. So when I was thinking of this project during COVID, I was trying to think, well, what can people do on their own that doesn't cost any money, that can be accessible to everybody to improve sleep? So I think, and research shows, that the answer could be bibliotherapy. And so this is a term which describes using books to improve health, and there is lots of research on bibliotherapy. So if you want to know more, please come and have a chat and I can point you in the right direction. But in the interest of time, it can improve various aspects of health. And so whilst various models of bibliotherapy exist, none have specifically targeted sleep. And in that case, well, why do I think that this might improve sleep? Well, there's lots of survey data. So I think Liz Coulthard and colleagues actually did a paper recently where I think it was reading was one of the most helpful self-help behaviours to get you off to sleep. But there's also been various other studies of shared reading groups, things like this. And the findings have been that neuropsychiatric symptoms have been reduced. And within neuropsychiatric symptoms is a measure of nighttime behaviours. So are people going to sleep at consistent times? Are they really tired during the day? Are they taking lots of naps? And so if they're reduced as a result of all these shared reading groups, it does suggest that there is an element of sleep that's being, sleep quality that's being improved upon here. But as I said, there are no interventions and no rigorous sleep measures. So to address this, that's where my research comes in. So I'm using a pre and post test design. So it's kind of like no reading for 2 weeks, read for 4 weeks, no reading for 2 weeks again. Using gold standard sleep measures to examine whether nightly reading can improve sleep in as little as 4 weeks. So to achieve this, I'm asking 60 adults with and without dementia to participate, and it's across an 8-week period. So some of the measures that I'm using include sleep weight monitors, daily diaries, and I'm capturing other measures of health, such as neuropsychiatric symptoms, well-being, mood. So I have some exciting news because I've just completed one, full study with 15 people, and so far the preliminary data shows a significant improvement in sleep quality. So if this trend continues, then the simple act of just picking up a book each night could actually serve to ameliorate some of these negative consequences around sleep. So another aspect that I wanted to include as well is I'm actually including people with subjective cognitive decline because these people represent an increased risk of developing dementia. So if we can improve sleep early on, that also then might help to reduce the risk of conversion to dementia. So thanks for listening to me waffle on. If you have any questions, I'll be on the panel after. So thank you very much.